All right, thanks everybody. We're going to go ahead and get started. I have made sure I hit the record button so that you will have the recording of this session and all the slides. Today we are having our second session for the Store It Safe Quality Improvement Project, and we are going to be focusing today on data. We don't have anything to disclose. Again, we want to thank the Ohio Department of Health for all the support they provide for the project. As a reminder, these are our participating practices. Please be sure that you chat your name and practice into the chat box. I'll keep giving that reminder as we go through the project. I know some folks may join us a bit later. On the agenda today, like I said, it's pretty much day to day. Dr. Gittleman, who is a co-medical director for Store It Safe. You met Dr. Denny on the last session, so Dr. Gittleman is her counterpart on the project. He's going to talk to us about why data is so important and what we do with it. And then I'm going to go through in probably what's going to be like excruciating detail, some of the project data requirements and details. So I will toss it over to Dr. Gittleman. And I just put in kind of a slide to show some of the data from our last wave of the project, Dr. Gittleman, as you kind of talk about why it's so important and what we do with it.
Sure. Thanks, Kristen. So I feel that I don't have a lot of slides because I figured we could just talk for a second. I feel that a lot of the times people hear data and they get very worried and they say more work, they say research, they say, I don't think I can do this. And really what the data is just as when we were in medical school and someone says to you, if you didn't document it, you didn't do it, right? And so that's really all data is. It's documentation of the work that you are doing. And why it's so important is if we don't document or we don't keep tabs on it, how do we know we're doing a good job? And if we're not doing a good job, how do we do it better? That's the whole idea of the quality improvement piece of this program. If we are doing a good job in one area and not another, we're not sure. And that's the only way is to be able to look at our data sets to say we are making a difference. A lot of time what ends up happening is we say, oh yeah, we're really doing this. We saw that in a matter of fact, I think it was maybe 10 years ago, we asked pediatricians to tell us what injury prevention topics they were talking about. And on at least 5 or 6 topics on every age, 80% said they were talking about this. When we looked at their data, it was only 20% of the time they were talking about it. So it's really important for us to capture exactly what's being done so we can make change. So as you can see, as Kristen put up, in the upper left corner is our screening rates. Well, you could see a lot of people were screening pretty well for depression. We weren't screening very well for suicide at all. And as you can see, it improved over time. Unfortunately, our end data, we still only got to about 60%. And we'd love to see that in this wave be even higher, that we're screening more and that we're counseling about lethal means more. And I know Kristen's going to talk to you about some of the data that we're capturing. The other thing that was really interesting to see was, who screened at risk for depression, who screened at risk for suicide, and also to compare family practice programs versus pediatric programs, because there was differences. And being able to see these differences allows us to say, boy, we need to concentrate maybe more in the family practice on depression, and in pediatrics, maybe they're doing that more. We need to concentrate more on suicide. And that's when you start putting in our PDSA cycles to say, what do we need to do to make changes to make a difference? So I know that when you see all the data that we're talking about today, everyone's going to take a step back and say, that seems like a lot of work. It really isn't. It's work that you're already doing. We're just trying to capture it so that we can actually talk through and show, especially to each of us, and make sure that we're doing better care for our patients, but also be able to go back to the funders and say, we are making a difference and that this is really important. So I will turn it over to Kristen and allow her to tell you a little bit about all the data sets we're capturing and then how we're going to use that data moving forward. And I'll be here the whole time and you can ask any questions along the way.
Yeah, so please feel free. We're a smallish group, so don't hesitate to unmute yourself and interrupt me or chat your questions into the chat. Dr. Gittleman will be looking at that as I'm talking. So for our project data, I've really broken it down into 4 main buckets, some of which you already have some experience with and we've already talked some about. So confidence data, pre-work survey data, baseline data, and monthly action period data. And I want to stress, like we said in the first learning session, this really does require teamwork. It can't be one person's responsibility to get data done. It just like we talked with all the other elements of the project. It's going to be a team approach, and we're going to talk about that some today. Everyone's flow isn't necessarily going to look the same. We're going to discuss with you sort of what we recommend, but every practice is different, and you may need to make some tweaks, and we'll talk about that a bit. So confidence data, like I said, you know already what this is. Many of you have already done the survey. It's a very brief survey. We need every provider, so that's MD, DO, nurse practitioners, to complete that. You're going to do a pre, a mid, and a post. Most of you have already done the pre. That should be done if you haven't done it by the end of November, and I'll include the link to that. It's on the slide, but I'll also include it in the follow-up email. Mid, we're going to do in February, and the post is going to be done in May. Again, it takes probably 2 to 3 minutes to do, and it just is going to tell us how confident you feel about the skills that we're trying to gain in the project. Pre-work survey data. So many of you have already done this. This is a bit longer survey, but it's still fairly brief. It does give us important information about your practice and your population. This only has to be completed once for the entire clinic. So not everyone is doing this. It's often best if it's done by the lead provider with the assistance of the office manager. Some of that information is just kind of more easily, usually the office manager has access to that. And again, that is due by the end of the month. So if anyone's having any trouble completing that, let me know. And again, I'll include that link. The data we haven't really talked in detail about, it was included, the description about this in your recruitment packet, but baseline data. So again, this is data that helps us understand specifically related to the activities we're very interested in the project, what you were doing before the project started. Now, we would love and try in every way to make collecting data and reporting data as easy as possible and as efficient as possible, and to take you as less time as possible. We would love to be able to do this via a quick and easy EHR report, but the reality is those just often don't exist, and trying to set them up is too time consuming and cumbersome, and many practices just can't do that. So we have to rely on chart review. And for the project, what we're going to be asking for is 7 randomly selected age 12 to 21 charts for each provider that's participating for the months of December 2022, February 2023, and April 2023. So it's sort of like the past year, kind of similar time frame, but in the past year. And so it will be a total of 21 charts per provider. So one of the things you should start thinking about now is who's going to do these chart reviews. Is that something you're going to want each provider to do for themselves? Is that something you might have a medical student or other staff in the office that could do? There won't be any baseline data required for residents who are participating, so it will be only the attendings that will need to do that. And we would like to have baseline data submitted by December 31st. So there is a link, and I'm going to just hopefully click on that, and hopefully this is going to work. Are you able to see my screen with the baseline data collection form?
Yeah.
Or are you still seeing? Okay, good. All right. So when you get the link, again, this is going to be pretty quick and easy, but you're going to select your practice. We'll just do Ashtabula since they're at the top. You're going to select which provider it is, what month you're entering the chart review for, the date of the appointment, which obviously it'll fall in those, that month that we talked about, who's completing the chart review, the age of the patient, was a depression screening completed, yes or no, based on what you see in the chart at that visit. Then what depression screening tool was used. If it happens to be a PHQ, we're going to ask you what that score was, if that's documented. It may not be documented, but if it is, you're going to select these. If it's one of these other measures, we're not going to get any more detail on that. Same with suicidality screening. Was that completed? If it happens to be an ASQ, there's going to be some additional detail about that. But if it's a Columbia or something else, we're not going to ask for more detail. And then was there documentation in the chart that there was lethal means safety? And that's going to be a yes, no. And if it's a yes, if there is any indication on what actually was discussed with the provider. And that's going to be one chart. And so again, it's going to be 7 charts for those particular months. So let me see if I can go back to my slides. Are we back to seeing slides? I just want to make sure.
Yes.
Okay, great. Any questions about baseline data at this point? Like I said, it's pretty straightforward. It's pretty simple. It will be a bit time consuming, but again, if you get your charts out and ready, you'll probably be able to go through them pretty quickly.
There is a message, question in the chat.
Oh, great. Thank you for letting me know that. Let's take a look at that. Are these visits supposed to be well care or any adolescent visit? Great question. They're supposed to be what we call adolescent preventative visits. So a well care check or a sports physical, either of those would count. Great question.
Can I ask a question, please?
Yes.
We are several providers in clinic. Like when I pick 7 charts, should they be my patients or anyone? Is it better to do it for anyone in the clinic?
So it would be 7 charts for a participating provider. So for example, if you and your colleague, Dr. Jones, are both participating in the project, your chart reviews would be 7 charts for you for those 3 months. 7 each, and then Dr. Jones would have 7 chart reviews for his patients for those 3 months.
Okay. Can I ask one more question? I don't want to delay everyone. We do have questionnaires that we ask all adolescents. We do ask if they carry a gun and things like that, but we do not ask, there's no ASQ built in. So that's gonna be, we don't do it, right?
Correct. That's correct. And you're going to have a lot of no's. That's why I said this may go very quickly, because it could be, we don't do a suicidality screening. And so all those will be no, no, no. So that'll go quickly.
What about for providers who had not started working at that time period?
I just saw that question. So if you have providers who are participating in the clinic, in the project, but they were not in the clinic during those time periods, I think Dr. Gittleman jump in, but I think we just would not have baseline data for those providers for those months.
Right. We wouldn't have any baseline data for those providers. And the reason why we need it for each provider is because the provider is the one that we're looking at to say, is our behavior changing? So it's not the overall practice, it's each individual provider. And as the last person said, you might think we do depression screening, but we don't do ASQ. Well, you might only be doing depression screening, some providers 50% of the time. That's why it's helpful to look at the baseline data.
Those are really great questions. And if you have a situation like that, where you do have a provider who was not there during those months, just let me know that. So then I know not to look for baseline data for them for those months. All right, and then the monthly action period data. So this is kind of what I say is the bread and butter of the project. It helps us really know if our education and our interventions are occurring. and what the parent and caregiver reactions are to those interventions. That's a new piece of the project this time, which I'll talk about a little bit more. So provider and clinic staff are going to be entering this data. We have to have some way to collect it. And again, EHR reporting would be great, but that's not feasible. And then the parent and caregiver will be entering some. This is what your iPads are for. You should, many of you have already reached out to me. You probably have your iPads. So we've tried again to think of a way to do this as quickly, simply, and as streamlined as possible. So you'll be using the iPad to enter this data after every age 12 to 21 preventative visit. That's a well or sports physical. And we want to get started on December 1, which I know is Friday. So we don't expect things to be rolling perfectly, certainly in December, but it's our start point. And we're going to be looking at rates. So to do that, to look at screening rates, to look at rates of lethal means restriction discussions, we have to have and get a report of the total number of those age patient visits that you had per month per practice. So think about who at your practice will be able to provide that to me for each month. So for example, in early January, I'll reach out probably to your practice manager and just remind them to give me that number. That's our denominator number that we're going to use to calculate rates. If your practice happens to be struggling, we may actually need to ask for that total number of patients by provider so that we can tell, well, Dr. Jones is struggling with getting suicidality screenings done. So let's try to figure out why. And, it could be a particular provider that's pulling the rate down for a practice, but we only go that route if we're sort of seeing struggles. And then the way that it's going to be done, you're going to be doing this daily as you go. So you're not going to have like a lot of data to enter at the end of the month. It should really be done. But we want everything to kind of be wrapped up by the 5th of the following month. And have your denominator so that we'll be able to run the charts. So for example, January 2024 data is all due February 5th. Now we're going to do a little sneak peek in December to see how you're doing, because we just don't want like a month and a half to go by without giving you any kind of feedback. So on December 20th, I'm going to pull out the data that we have and ask for that denominator number for December 1st through the 20th, if we can get that, or at least an estimate. And then we will have some initial charts to just look at and see how we're doing on certain metrics, which I'll talk about those particular metrics in just a minute. But before I move on, I kind of want to stop and see if we have any questions, and I'll also just check in the chat. I think we had a question in the chat, even if all providers are not participating. So if all providers are not participating, then we are only getting baseline data and monthly data for the participating providers. So the rest of your providers would not be providing any baseline data or additional data. It would only be for the providers that are participating. Hopefully that's clear.
Well, and I'll just add to that we have found once you put changes into the practice so that you're putting these tools into place, it's a lot easier for other providers to do it as well, because you're doing systematic changes in the practice. So then other providers now get the MOC credit and get to participate. So when one or two are doing it, if one doesn't want to, it's a lot easier for them to be included.
All right, a couple of things I just want to mention, and you'll see why this is so important. So many of you have reached out to me and given me the names and credentials and emails of all your participating providers. But if you haven't, make sure that you do that. And because of the selecting, like I said, when you go into enter data, we have to have everyone's name in there. And also I need that for MOC4 credit. I know that some of you have residents that are participating. So if you do have residents, please let me know that. Again, we're going to need to have their names and credentials and emails for MOC credit that many of them can bank. But they're not going to be technically a part of the data entry process. That will all be done under the attending's name. And I just wanted to give you kind of a look at what monthly data charts we're going to be seeing. So, the first thing we have to look at is how often are you basically completing the data tool? Because if you're not completing that, then we really have no idea what is going on. So that's the first rate that we look at. How many times do you get that data entered on the iPad for all those appointments that you should be entering it? We look at depression screening rate. We're going to be able to show you for your population where they fall in terms of their depression. Are they at risk? A mild, moderate? Same thing for suicidality screening rate. We're going to look at lethal means discussion rates, providing the SIS resources, how often you offer the lockbox and how often it's accepted, and then if there's treatment plan initiation or continuation when that's indicated, and then the family feedback surveys, which again, you'll see kind of what that looks like in just a minute, but how often are families actually completing the post-appointment survey, and then how often are they reporting that they've received lethal means discussion or received resources, the likelihood of change based on those conversations and resources. And then how often have they ever heard these type of discussions from anyone other than the provider. So on to iPads. Again, we're giving these to you because we think that this is going to be a quick and efficient way to enter data and take a lot of the time burden off of you. So you should have received your iPads by now. If you haven't, let me know that. Make sure when you are getting them that you do check that you have the iPad and the charger. One thing that you're going to need to keep in mind is these are going to have to be kept charged and kind of ready to go each day. So think about that process and who's going to be responsible for that. Go ahead and power them on and get on your clinic Wi-Fi. That's one of the first things. I will let you know the iPads are not locked down. They are very streamlined. We don't lock them down because there's a lot of clinics that when that happens, there's no way to get on Wi-Fi with a locked down iPad. And basically it's going to be two buttons that you're going to be using and then the touch screen. That top button is I call the top button or the power button. And then the little circle button obviously is called the home button. So your screen on your iPad is going to look much like the picture on the left. That's what you're going to see when it's started up. And the little gray sort of circly button on the left at the bottom, that's what you click on to go to your settings and get on your clinic Wi-Fi. That SIS button in the middle is when you pull that up, that's what's going to pull up your data entry. And I'm going to, let me just show you that now so that you can see what that's going to look like. And we kind of give you a reminder that at the beginning, it's going to be a provider office staff entering, and we're actually going to enter some data in a minute with a case. But this is kind of what it's going to look like for you when you see it.
I don't think it opened or launched for us.
Oh, let me see. Is anybody seeing that now?
It did not open.
Okay, let's try this. All right, let me pull this up and try to share again. There we go. Are you seeing that now?
Yes.
Okay, so this is what it's going to look like. And again, we'll go through this in a moment when we have a case, and I'll show you kind of how to enter the data, but it's really just several clicks. And then at the end, there's going to be a submit button. It will kind of pop up and allow you to then pass the iPad to the family so they can do their portion of the survey.
Yeah.
All right, I'm going to go back to my, try to go back to my slides. Just 1 second. Any other questions at this point about the iPads? And have most of you gotten them? Is there anybody who hasn't gotten your iPads? If you haven't, definitely let me know that. All right, and so one of the things that I wanted to do today, because at the last session, we did kind of talk about some workflows. And that's one of your first tasks, is develop a workflow around all these new things that you're doing. So we talked some about already screening last time. We talked a bit about the lethal means restriction discussion and giving resources. And so today now we're kind of adding data entry into all that. So this flow is a lot. I'm not going to go through every step. This is really going to be a template for you to use when you do your flow for your practice. You'll be able to tweak this and change things around. But this kind of encompasses in detail the full flow with everything that you're going to be doing. And so I'm going to walk through that in a few steps. So like we talked about, there's probably going to be tasks that your front office staff is going to do. Maybe a little different clinic to clinic, but generally probably going to have those staff doing some things. Your clinical staff, they're likely going to have some roles, and your providers are going to have certain roles and tasks. And again, we're giving you today what we recommend, but it may look different in your practice. So for example, for office staff, this may be someone each day who checks that the iPad is charged and ready for the day. They may be the person at check-in that gives both the depression and suicidality screenings to the patients to complete in the waiting room. And then they may be the person at the end of the day that collects the iPads, make sure they're cleaned, put in a certain location to charge. That, like I said, that's something that when we've thought about clinic flow, probably would be a good strategy. And then for your clinical staff, for MA nursing staff, some ideas that, again, your practice may do it this way. You may have it be a bit different. They may be the person that picks up the iPad from the designated area. They may collect and score the screenings, the depression and the suicidality screening. And then their job may be on the iPad to get the data entry started. So to do that, they'd press the home button twice. They would click on that SIS icon that I showed you, and then the data tool would be started and they would enter some of the data. And I'll show you when we go through the case what that might look like. And then they would complete questions 1 through 9 in the data. They would room the patient and then just press that top button on the iPad to put it to sleep, that some of the data entry's been done, but then the rest would be left for the provider to do. And then the provider, again, recommended flow for that role at the clinic. So they would come into the appointment, or before they came into the room, they would click the home button on the iPad to look at what the results of the screening were. So it actually does tell you if the MA or nurse enters the scores and enters the screening results, that will be visible on the iPad for the provider. Review the screening results with the parent or patient. Press the button on top of the iPad to put the iPad to sleep while they finish the well visit. So they would do their well visit, have the lethal means discussion, provide the resources after the safety lockbox. Again, press the button, press the home button twice, and complete these questions in the data collection tool. And then they would click submit. And at that point, all of the clinic data has been entered. Then they would ask the family to voluntarily complete a survey. It's totally voluntary. If they don't want to do it, they don't. And it does describe that. You'll see that in the top of the family survey. So if there is no caregiver or parent present, or if they do not want to complete the survey, there's a particular button they would push and everything is done. It's ready to go back and start again. But if the family is there, they would press that button and they're willing to do the survey, give the iPad to them, and then the parent would complete that. And then you're kind of done with that entry. You need to, again, they'll think of that process where the iPad goes back to be ready for the next appointment. And again, this is just a summary of kind of all those steps in excruciating detail. So you're going to get a better feel for this when you start doing it and when you actually talk with the rest of the folks in your practice about it. So I'm going to stop there for any questions before we kind of go through a case and you actually see the data entry. Let me just quickly also check the chat. All right, so we're going to go through data entry for a particular case, and I may have to do that little shuffle around to share. So Rose is a 12-year-old Caucasian female who comes to your office for her annual well visit. She has Medicaid insurance, and her mother is bringing her to the visit. She checks in at the front desk and does complete the depression and suicidality screening. Those are scored, and she is found to be at risk and in the mild range for depression and no potential risk identified for suicidality. She does not currently have a treatment plan in place for depression. And based on her depression screening results, you schedule her back to do a more thorough assessment of her depression and discuss treatment options. You discuss lethal means restriction with Rose's mother and offer her a safety lockbox. Her mother declines the box. You forgot to give the SIS resources to Rose and her mother, and Rose's mother does agree to complete the post-appointment family survey. So let me pull up data entry and show you kind of what we would do. And let me go to Zoom. Where are you, Zoom? I've lost Zoom completely. All right, I'm going to stop share. And then we're going to start share again. All right, and you should again be seeing that data entry. Is everybody seeing that?
Yes.
Okay, so at this point, we're going to assume that I'm an MA and I have collected the screening results from Rose and I have scored those. So I'm going to enter my practice name. I'm going to enter the provider that she's seeing. I'm going to enter the date of the visit, which we're going to say today. Rose was 12 years old, so that's a drop-down box. She does identify her gender as female. She is Caucasian and she has Medicaid insurance. So we're going to move to the next. I scored the results of her screening, so it was completed. She scored at risk for depression. She did complete a suicidality screening, and she did not indicate any risk on that assessment. This is where the MA would stop and put the iPad to sleep, and leave the iPad wherever you want to indicate for the provider. When the provider picks up the iPad and opens it, they will see what the results of the screenings are. So it's important to know that, obviously, before you're having conversations with the patient and family. So you're utilizing the screening results. So the provider would then do their appointment as indicated, have the lethal means restriction discussions, which we're going to talk about much more detail at our next learning session next week. Complete the appointment and then enter this. Please select all the items that you discussed with the family that should be kept locked away and inaccessible. We discussed them all. Did you discuss and or provide resources? Oops, no, I forgot that. I did offer a lockbox. They did not take it. And then based on today's depression screening, so some changes were made. Because you are going to have them come back for an assessment. And then what you're going to say is close primary care follow-up. Is the parent or adult present? Yes, they are. You can put any information you want in that box. You don't have to, and submit. Now your data is totally done and submitted. The parent is present and does want to do the survey. And then this is what the parents will see. So it gives the explanation, again, voluntary. They pick their practice, they pick their provider, they enter any of this information based on what their perception was. They didn't receive resources. They say whether this is going to impact anything they do at home. And then they say yes or no, and they can enter any information, and then they click submit. So that is data entry, and it's then completely done. It will refresh, and you should be ready for the next provider. So I need to also just go back so that I can share the slides again. But I'm going to stop there and again, see if we have any questions, thoughts, or comments. and check the chat. Now, like I said, I know that sounds a lot, and I've gone into annoying levels of detail about it. You're going to get a feel for it when you start doing it. Also, what I would suggest to you is if you feel that the flow that we've talked about and that you see when I send you these slides and you have that kind of overarching flow doesn't work for your practice or needs to be sort of deviated from, let's talk about that so that maybe we can help with any of those parts. If they can't read English, do we only do our part? I think that's a great question. We don't have the survey translated, so you could do one of two things. Yes, you could only do your part, and especially because you probably wouldn't have a translator or someone available. So I think you probably would only be able to do your part in that situation. Dr. Gittleman, any other thoughts on that?
No, I mean, we want as much data as possible so we can say, everyone's doing a great job. And if there's problems, then we can help. I will tell you that Kristen is incredibly available. Sarah and I are always available, so you can always send emails. And the
Yes.
other thing is, as Kristen kind of suggested, this is multiple people in the office working together. If one person thinks they could just do it all, it is a lot to do. But if each person does their own little part, and that's part of the PDSA cycle, it actually is not as cumbersome as it looks.
And yes, we have a question about the resources. So besides the iPads that you've probably already gotten, our printer has shipped out the paper resources to you. So I know we showed those to you last time. So you'll be getting a bulk of those in print as well. And then tomorrow we are shipping out your lock boxes. So you'll be getting those as well. So yes, you ultimately will have the iPads, the printed resources, and lock boxes. And all you need to do when you start to get low on any of those is let me know, and then more will come out to you. Also, in terms of the iPads, if you had only one provider listed, we only sent you one iPad. But if you had multiples, some of you may have gotten 3 iPads. So if you're a clinic that you're just now letting me know, we're going to have actually more people, which we love, great. I can send you more iPads. You just need to let me know that you need a couple more. So don't hesitate to do that if you feel like one iPad is not going to be enough for your practice. Like I said, several of you got 3 iPads, so who had more than obviously one provider participating. So a few things to get working on now. So on your task list that we looked at last time, your workflow is due by the 15th of the month. So again, I am not picky or choosy on how you do that. You're going to have the slides that you can use as a template to change and add your own kind of tweaks to. And then you can also write it on paper and scan it and email it, either way that you prefer. And I'm also here to help with that. So if you have questions, please let me know. Be sure that your lead provider and office manager, that one of the two of you have finished and submitted that pre-work survey. Be sure all participating providers have completed the pre-program confidence survey. And again, I've been seeing tons of those come through. So at the end of the month, I'm going to start going through and checking off who's done it and who hasn't. So you'll get reminders if you haven't, but go ahead and do that. Also, start thinking about baseline data that's due at the end of December. Have a plan on how you're going to get that done. Again, is it going to be each provider doing it? Do you have other resources in the office to help get that done? And be sure you have all of the names, credentials, and emails of everybody to me as soon as you possibly can. So we make sure everybody's name is in the data entry and that I have everything I need as we're tracking credit for MOC. And Friday, this is our official start your process. It does not have to be perfect. It is a get started. It is a line in the sand of when we're going to start looking at data. So don't panic about, oh my gosh, we're learning so much. We haven't even learned about lethal means discussion. Like, just start doing things and getting things into place. And I would say really start thinking about how you're going to educate everybody else in the practice that's going to be doing this. Do they need to watch the recordings of these lessons. I'm always happy to have calls with any of you or any of your staff that have questions or want to do that. So don't hesitate to let me know. But we kind of rely a lot on the trickle down of education and what to do. So we have a lot of providers on these calls. We do have a lot of office managers. I know we have some MAs, but probably there's people on here who are going to have to be doing things that aren't hearing this. So think about if you're going to talk about it at a staff meeting or how you want to do that. That's also very important. Okay, I am one provider with 2 residents. Would the residents enter their data under my name? Yes, they would. Your residents can get their MOC credit to bank. And I think I may already have their names. I'll double check that, but and I saw Dr. Gittleman did answer that. Yes, they are, as he said, extenders to that provider. And then just a reminder that next week, on Thursday, is going to be our 3rd and final learning session. That's going to be December 7th from 12 to 1. I will make sure everybody is on that invite. We actually have, I think, a few new folks that I'll make sure. This is really getting into the nitty-gritty of the lethal means restriction discussion, which often is the trickiest piece of this, because you're talking to patients, you're trying to provide anticipatory guidance. And so we're going to talk about that much more in depth. And we would love to have as many of the providers that are participating as possible so that they all can hear this and learn this together. But we also know that, it's hard to get everybody on a call, so there will be a recording of that as well. I do see a question in the chat. What if 2 teens in a row? Can you use paper questions? So we don't have a paper questionnaire, and we didn't do that on purpose because we've done that in the past and we've really found data gets lost, data doesn't get entered. So if you are a practice that feels like you might have 2 well visits going on at the same time, we could send you another iPad for that. And now here is sibling teens. So you're saying you have 2 in that age group that come for an appointment together. I think you would just enter one's data and then enter the other one's right after that. And then on the final one that you enter is when you would give the family the option to complete that survey. But Dr. Gittleman, do you want to chime in on any of those questions? Great questions, by the way.
Again, we want to do the best we can and get as many as possible. So if it's possible, if you have twins that are together and get both of them, great. If you get one and then the family has to run out, well, you can only do the best you can do. That's why we're not asking for 100%, but we would like to see close to 90%. And we're going to have every once in a while one that might not be able to, be captured.
All right, we have just a few minutes remaining. So any additional questions or comments? All right, if not, please remember, some of you have been reaching out to me with questions, calling me, sending me an email. I'm always happy to answer questions, especially as you get started. Things are going to come up. You're going to have questions. So do not hesitate. I get emails on my phone, and I love to distract myself from anything by checking emails. So feel free to email me. Also, feel free to give me a call if you want to have an individual chat about any questions, or like I said, as you're doing your workflow, I'm also happy to talk through any changes or things like that. So again, same question like about the sibling teams. I think we would, I think Dr. Gittleman kind of answered that beautifully too. So do your best. There are going to be some situations where you're going to miss someone. We totally expect that's going to happen. But we're trying to get into habits with things. So, trying to catch as many as you can at those preventative visits is what we're shooting for. All right, if there are no other questions, then we are done for today. I will Make sure you have a follow-up email with all that important information and a link to the recording. And then just a reminder again about next week. I'll send out some reminders when we get closer to Thursday. Thank you.